I'd like to thank the organizers for giving me the opportunity to speak on the topic of new approaches for bicuspid valve disease. Here are my disclosures. One of the challenges with treating bicuspid valve disease is that TAVR devices are designed to treat a relatively circular annulus. Since we're not removing the leaflets, heavy calcium may lead to asymmetry. And so there's a lot of concerns with bicuspid valves in general. The first is that usually patients have a large asymmetric annulus, and this could lead to paravalvular regurgitation. As you can see from this cartoon, ideally a trileaflet valve will expand circularly and sort of fill the gaps at the level of the annulus. In a bicuspid valve, there may not be complete circular deployment, and because of the large asymmetric nature, you may have gaps through which you can get paravalvular regurgitation. Another concern is that bicuspid valves often have a heavily calcified raphe, as you can see here where the red arrow is. And that often leads to the valve deploying asymmetrically in the opposite direction. And in this type of example, if it deploys asymmetrically and there's not enough room in this direction, you can create a contractile injury and lead to annular rupture or root injury. You have to be very cautious about that. There's also, when you have this heavily calcified raphe, and heavy calcium, you can lead to a non-circular deployment, as you see here, in sort of an elliptical fashion. Now, especially with balloon expandable valves or intraannular devices, non-circular deployment can lead to abnormal leaflet function. You can see here that one of the leaflets is not opening normally. And acutely, the hemodynamics are okay, but over time, this may lead to early leaflet degeneration and valve failure. And finally, bicuspid valve is often associated with concomitant pathology, such as aortic root dilatation. And so you have to take that into consideration, and if you just treat the valve, you may be performing an incomplete treatment for that patient. One of the challenges is we don't have a lot of data with bicuspid valve disease and TAVR. Some important questions that are still not fully answered is, does valve type matter? Are the procedure results comparable to tricuspid valves? What about durability? And as mentioned earlier, what about concomitant aortopathy? So one of the initial studies that was presented was from Yoon et al. Presented in JACC in 2016. And this was early experience with bicuspid valve disease with first generation devices for the most part. They looked at some second generation devices. And some important complications that came out early with the first generation especially was paravalvular regurgitation. Pacemaker rates were maybe a little bit higher, but not clear. But when you look here, there's a high rate, especially with core valve in the study, with second valve implantation. And as I said, this was an early experience. I think one of the challenges with bicuspid early on, and still remains a challenge, is there's a lot of variability in disease presentation. And this is a new proposed calcification by Hassan Jalahawi. Typically we do it as type 0, type 1, type 2. But in terms of TAVR, the more relevant thing is, where is the calcium? How is the valve going to expand? And this new proposed calcification sort of tries to address that. This bicommissural non-raphe type is sort of a type 0. And you can see here sometimes coronary cusp fusion or sort of heavy calcification. This is really in the middle and on the left, sort of that type 1, where you get fusion of the raphe. And there's a lot of variability in this as well, depending on where the fusion occurs, how much calcium it is, and everything else. And all of these are important characteristics, and this is something that really need to look into more detail. The degree of calcium also matters a lot, because this is what will dictate valve expansion. And so when there's heavy calcium, especially such as this, you have to make sure that there's enough room in the root for the valve to sit, because this calcium may not allow the valve to expand in one direction. So you have to really focus on the calcium and the root size as well, and see, will the valve have enough room to expand? When you see an example here, heavily calcified raphe will prevent the valve from expanding in the direction of the raphe. The valve will sit towards the other side and may be asymmetrical as seen here. This is an example of a type 0 bicuspid. Again, very thick leaflets, not the densest calcium, but very thick fused leaflets. And especially in these type 0s, the sealing zone of the valve will be at the leaflet tips. Now, it may not necessarily be at the annulus, and so valve deployment may be higher in order to ensure an adequate seal. What you can see in this case example is there's not a ton of aortic regurgitation, but on the echo here, you see a very asymmetrical valve deployment which is even at the level of the leaflets. It's not down here, but where you see where the line, the X-plane is, it's at the level of the leaflets. There isn't much AR, but the mean gradient for this 29 millimeter core valve is 13. So we post-dilated with a 20 millimeter balloon, and what you'll see is the leaflet, it's more circular, and the mean gradient came down to 5. So in this case, post-dilatation was not done not for AR, but for that asymmetry. Here's an example of a bicuspid valve with minimal calcification. And you see here minimal calcium. And in this type of case example, I often do a BAV because you can see, especially if you have fusion of the right and non, and they have a small left leaflet, you can see on the BAV if the balloon pushes towards the left coronary, there may be a concern about left coronary occlusion even if the sinus is large. So in this case example, the balloon remained central, there was good expansion. We felt comfortable doing a balloon expandable Sapien XT in this case, and there was trace regurgitation at the end. In the end, you have to be careful of heavy calcification. And this is an example of a case where, because you need adequate radial strength, and this was an accurate valve that you see here. And you see in one dimension the valve looks expanded, but in the other dimension the valve is sort of pancaked by that heavy calcium. The device just doesn't have enough radial strength to expand. There's been a lot of talk about the potential benefits of LOTUS in bicuspid valves. And you see here again a case example of a type 1 bicuspid, heavily calcified raphe with a lot of calcium. And you see the acute result here is very good and with minimal AR. On echo, we had trace PVL, a mean gradient of 10 with this 27 millimeter LOTUS, and a valve area of 2. Some of the advantages of LOTUS in bicuspid valve is that it's fully retrievable and repositionable, which may allow you to reposition and ensure a seal. Its deployment is via gradual mechanical expansion. So it has radial strength, but it's gradually applied. And I think this reduces the potential for annular rupture. And the adaptive seal and the ability to conform to irregular surfaces helps reduce PVL. There was some data presented last year from the RESPOND registry looking at, this was post-approval, just sort of commercial use. But these were, the bicuspid valves were identified by the site and confirmed by a core lab or CT, and the valve sizing is up to the operators. It's not a large number, there's 31 bicuspids, the majority of which were type 1 bicuspids. But acutely, the results were good. You know, the mean gradients were maybe a little bit higher, not significance, but it's small numbers again. Mean gradients of around 13 in the bicuspid with the valve area that was a little bit smaller at about 1.6. And I think that's important to sort of note. And that may be an issue, one potential limitation in treating bicuspids. But what you see here in this registry is very minimal PVL. No patients with moderate PVL in the bicuspid arm. So there are lots of considerations in choosing THV in bicuspid, but annular size regarding seal, presence of a heavily calcified raphe to account for potential for annular rupture or PVL or elliptical deployment, looking at root size, and all of these things have to be taken into consideration when choosing which valve type and whether it's safe to treat a bicuspid valve. So in general, bicuspid valves can be done, but you should proceed with caution. Thank you very much.